thank you for joining us. My name is Pat Borgen. I am the chairman of the Department of Surgery at Maimonides Medical Center in Brooklyn, New York. I also founded Brooklyn's first breast cancer program at Maimonides. I also chair the Miami Breast Conference for MJH. Welcome to a discussion of lobular breast cancer hosted by CancerNetwork, Oncology Nursing News, and Cure Today. I'll be your moderator. We've got a spectacular panel of experts, patients, nurses, advocates who will join the conversation. And I'm going to ask them now to introduce themselves, beginning with Patricia.
Hi, everybody. I'm Patty Jekyll. I am an advanced practice nurse in oncology. I was at UCLA for 34 years. The last 4 years, I've been doing consulting work. And I am the co-chair of the Miami Breast Nursing Session, and I'm the senior editor at Oncology Nursing News. And I am also a lobular breast cancer thriver. I was diagnosed 10 years ago. I had 3 years off treatment, and I recurred last October. So I am back on treatment, staying strong, and here to talk about lobular breast cancer.
Thank you, Patty. Thank you for joining us. Sunil?
Yes, thank you. So I'm Sunil Datta, or I go by Neil too, if that's easier. I'm a radiation oncologist at Emory University. Seeing various things, but particular focus is breast cancer and central nervous system tumors. And for the breast cancer, I work at Emory St. Joseph's, which has photon and brachytherapy options. And I'm also one of the lead breast radiation oncologists at our proton center as well. So a broad exposure to all the technologies from a radiation perspective.
Great. Welcome. It's so nice to have you, Sunil.
Thank you.
Arya?
Hi, everyone. I'm Arya Roy, and I'm a breast medical oncology assistant professor at The Ohio State University and at the James Comprehensive Cancer Center. And my main focus of interest is actually lobular breast cancer. And I do clinical and translational research in breast cancer, mainly in lobular breast cancer as well. And I'm one of the clinical leads for lobular breast cancer translational research at The Ohio State University. And I'm also interested in antibody drug conjugates and also newer therapeutic options in breast cancer in general. And I lead some of the investigator-initiated trials and some of the other clinical trials at The Ohio State University in breast cancer.
Great. So nice to have you. Welcome. Lori, welcome.
Thank you. Lori Petiti. I am a breast cancer advocate in Southern California. I was diagnosed in 2010 with stage 2 pleomorphic lobular breast cancer. I attended the first International Symposium for Lobular in 2016 at Pittsburgh, put on by Dr. Steffi Usterich. And from there, with a group of advocates, I became one of the founding members of the Lobular Breast Cancer Alliance. So my advocacy journey is going on 10 years strong, and I'm very happy to be here.
We are very, very happy you're here, Lori. Thank you for joining us. This is an ancient disease. Breast cancer was described in the Edwin Smith Papyrus in 1600 BC. Clearly, there were lobular cases. However, as an entity that we call invasive lobular, it's really 85 years old. It was described in 1941 by two pathologists at what was then the Memorial Hospital, Frederick Foote and Francis Stewart. Now, they were describing LCIS, and as an aside, they segued into invasive lobular disease. They were completely correct about invasive lobular and completely incorrect about LCIS. And 85 years later, we're still sort of struggling at times explaining to patients that LCIS is not actually breast cancer, although the C word is there. According to the last report of the NCI SEER database, there were 48,300 cases of breast cancer that included the word lobular. This included mixed tubulo-lobular, ductal lobular. About 70% of those were pure invasive lobular for an annual incidence of about 33,000 cases. My bias is that this disease should be viewed as a distinct disease entity, not a subset of ER-positive breast cancer. It arises not simply from the lobule, but from the terminal duct lobular unit. We'll talk about the foundational event, which is the loss of the ECA-adhering protein, and how that impacts the growth pattern and so many of the challenges that we face. We'll talk about the dominant actionable signaling axis, which is the PI3 kinase AKT mTOR pathway, which is altered in this disease in as many as 60 to 70% of cases. And finally, a highly distinctive estrogen receptor program, and we'll probably touch on ESR1 and how HER2 mutations, not amplification, plays into the story. And most interesting to me, as someone who was part of the BRCA1 and BRCA2 story, there's clearly the potential of identifying impaired homologous recombination, which may make some of these tumors susceptible to drugs like PARP inhibitors. So with that as kind of an introduction to this fascinating disease, I'm going to see if Dr. Roy or Dr. Dutta would like to jump in and talk a little bit about more foundational stuff from your perspective about invasive lobular disease.
We know that now it's actually we are getting a lot more interest in lobular breast cancer, and now actually our patients know about lobular breast cancer, because I have several patients in my clinic who actually ask me about lobular breast cancer, particularly when they have the diagnosis. So invasive lobular breast cancer is actually the second most common type of breast cancer in terms of the histology after the ductal breast cancer. And ILC is actually seen in 10 to 15% of the patients that we treat with breast cancer. And as we just mentioned, as Dr. Borjan just mentioned, the main classical feature of ILC is the loss of E-cadherin protein, because E-cadherin is the protein which actually helps the cells to stick together. So when we think about a breast cancer, we all think that, okay, it's a breast mass. That's what we are expecting in a mammogram. But from the diagnosis itself, the ILC is actually different from the invasive ductal cancer. Because if you're thinking about a mass in the mammogram, sometimes the ILC, you will not see a mass in the mammogram because it does not have the E-cadherin protein. So the cells cannot stick together. So they cannot stick together to form a mass. So instead of that, because of the loss of this protein, the cells actually seen like a file-like pattern or like a sheet-like pattern. So rather than forming a mass, sometimes you may just see in the mammogram that it's just like a cloudy appearance of the mammogram. Or you may say like there is like a diffuse growth of cells in the mammogram, or diffuse growth pattern in the mammogram rather than seeing as a mass, which we need to pay a lot more attention, because sometimes because of this misconception that all breast cancers always forms a mass, sometimes we can miss ILC in the mammograms. And that's why even if, especially in patients who have dense breast, which can actually, which in that cases, we might not be even able to see like small masses. And especially this file-like pattern can be missed in the dense breast patients. So it's always better to consider MRI scans in some cases where we are not completely sure about whether it's a mass versus a growth, where it's a calcification or something in the mammogram. So that is one of the distinct features of ILC when compared to the IDC or the ductal cancer, that it do not form a mass sometimes, it just form like a file-like pattern. So even if your mammogram is not calling out a mass, you need to make sure and ask your oncologist or ask your primary care doctor whoever is ordering your mammogram, just to make sure that we are not missing an ILC there.
I'm going to jump in there for just 1 second, because this is really from the surgical perspective, in particular, it's become a hot button topic. The world of breast cancer surgery has seen fantastic de-escalations from mastectomy to breast conservation, axillary dissection to sentinel node, whole breast to partial breast radiation to who doesn't need radiation. And along that pathway, MRI has become a political entity. There are doctors who go on the record as, I don't like MRI. I'm very proud I never ordered one, to doctors like me who really rely on MRI very, very much. It's not a screening test for sure, but in working up lobular cancer and in working up an abnormality and in planning surgery, I find it indispensable. And I wonder what you do back home at Emory and at Ohio State. It sounds like Ohio State is pro MRI. Bravo. I suspect Emory is pro MRI.
For ILC, yes, correct.
Yeah.
Same with Ohio State with ILC, as I see a lot more ILC patients. Again, the main thing is we want to make sure that we are getting clear margins, especially for the surgical purpose. It's always better to consider ILC because again, we have to see because of the file-like pattern, it's going to extend to like multiple quadrants. So especially if you're planning on lumpectomy, I always feel like it's better if we have an MRI. So at least like we can make sure that we are getting the whole mass or the whole part quadrants of the breast that's involved with the ILC or not.
So Sunil, obviously margins remain the coin of the realm. We want to give you the patient for radiation with the least possible disease burden. And the way we do that is by doing our best to ensure clear margins. It's a challenge with invasive lobular carcinomas. And for the surgeon, we don't feel the edges of these tumors during the surgery the way we do on a conventional ductal cancer. So I'm assuming at Emory that the same is true. You guys are paying close attention to margins. Talk a little bit about lobular cancer margins and also the radio responsiveness of invasive lobular carcinoma.
Right. So like you mentioned, MRI for staging can help should the patient want to go the lumpectomy plus radiation route, which is a nice package for ILC, which I'll get to in a second. And speaking of the margin, yes, I mean, no tumor on ink is what we like to see. And, I wouldn't say radiation is very good at making up for a positive margin. So if we're not able to get no tumor on ink, then, then we do discuss the option of a completion mastectomy in those cases. Regarding what you alluded to with the radiosensitivity of ILC, I would say that is one positive or good news aspect of ILC. They typically have biological features that don't, lead to radio resistance. They're usually low to intermediate grade, ER positive. So we have endocrine therapy on the backbone to help supplement our treatment. And they typically, in older women or postmenopausal women, where we know that those ER positive cancers are less likely to recur. And so while it is anatomically, infiltrative and sometimes upstaged, whether it be from a T1 to T2 up to a T3 at the time of surgery, as well as more often found to have positive sentinel nodes, we don't view it as a radio-resistant histology. And so our dose fractionation options are still open to whether it be the ultra hypofractionated, which is 5-fraction whole breast, or if we're treating lymph nodes, the moderate hypofractionation over 3 weeks. Those are still good options. And we also can limit our use of boost, which we know in itself increases fibrosis and toxicity for these patients.
Patricia, do you mind if we ask you how your initial cancer was diagnosed?
It was self-diagnosed. I looked down and I thought something strange there. But like any good oncology nurse, it was Super Bowl Sunday and I had a party to go to. So I didn't think too much about it. And it was 5 months after a negative mammogram and an ultrasound. And the same thing happened for my recent recurrence, which is 10 years out. I had a mammogram and ultrasound, had a lovely conversation with the radiologist. He spent a lot of time talking to me about, yes, mammogram's the way to go, ultrasound, I don't think you need an MRI. And then 5 months later, I sought a second opinion, did an MRI, and we found a tumor. So both times I was not given an MRI. And I think that's the problem. The patients, it's so much better than it was 10 years ago, Dr. Roy, and I'm so glad to hear that patients are coming and talking about lobular. I mean, I was at a large academic center and I was not told, and maybe I didn't ask the right questions because I was kind of in shock, that I was not told lobular is different. We need to look at it differently. We need to look at it through the lens of lobular and the science and the pathology behind it. all I knew, and I did not work in the breast cancer world when I was working as an advanced practice nurse. I worked in other solid tumors. And all I cared about was it ER/PR positive? Was it HER2 negative? All of the basics. We've come a long way in 10 years, but I think there's still a gap especially for patient education. And I know Lori knows that, working with the
Yeah.
Lobular Breast Cancer Alliance.
I
And
want to bring Lori in. Yeah. Because what you said, Patty, is just it's probably such a common story out there.
absolutely.
It's all too common. Lori, one of the big problems with the internet is there's no filter, and when news is old news, it stays on the internet. In the 1970s and into the 80s, surgeons who found invasive lobular cancer on the left would do a blind contralateral biopsy of the other breast. And in a handful of cases, they found LCIS. Somehow, invasive lobular cancer got labeled as that bilateral breast cancer. And that has stuck for 30 years. And there are surgeons out there that will tell patients, well, not only am I going to remove one breast, but this is a bilateral breast cancer and you have to remove the other breast. What do we do about that misinformation that's still out there today?
That's a very good point. And the internet gets bigger and bigger every day. Now we have AI chat bots that we all go to, and we kind of take everything they say as our new Dr. Google. But that's one of the things that the Lobular Breast Cancer Alliance really tries to do, is put the word out that everything on that site is evidence-based, scientifically sound. And there are resources for patients as well as physicians, but it's very patient focused, to be able to download things, brochures on questions to ask your doctor when you're first diagnosed, to be able to take in, to learn about your diagnosis. I always caution people to go right to social media when they're diagnosed, because you find a lot of anecdotal information, and everyone's diagnosis is so unique, and everyone's so unique. So it's a constant challenge, and we just keep trying to put the word out to look for these evidence-based, scientifically sound websites, and they are out there.
Let's go back to Dr. Roy, and I'd like to jump into some of the biology and some of the maybe controversies that are out there, some of which probably shouldn't be controversies. We know that the overwhelming lion's share of these cases are going to be dependent on estrogen, ER positive. The majority are HER2 negative. Is a genomic assay like the 21 gene oncotype assay accurate in invasive lobular cancers, and how do you use it?
Yeah, actually, that's a great question, because we have this debate all the time. And lobular breast cancer, usually, if there are different kinds like classic type, there is also pleomorphic, which is different than the classic type. Usually, the classic ILC is mostly highly estrogen receptor positive. Almost always, it's like 90 to 100% estrogen positive. The pleomorphic is different. It's highly aggressive, less estrogen positivity. But I'm mainly talking about the classic ILC part here. So if it's a classic ILC, it responds, of course, it's highly estrogen positive, so it responds very well to endocrine treatment, and it responds poorly to chemotherapy. Because it's a luminal A type, it's a slow growing type, it's a low grade type, so it's not going to respond much to adjuvant chemotherapy. Usually when I see a patient, even if the MRI is saying that the tumor is like 7 centimeter, I do not offer neoadjuvant chemotherapy to ILC patients, unless I always talk to my surgeon and see if they can actually get a clear margin, or if they're planning on lumpectomy versus mastectomy, then I decide my treatment accordingly. Because if you're planning on mastectomy, especially with this ILC, like higher ILC T3, when the size is more than 5 centimeters, I do not give them upfront chemotherapy, because sometimes we can see upstaging and sometimes we can even see downstaging of the tumors. because most in the surgery, most of them, sometimes MRI overestimates and sometimes MRI cannot estimate the size also of the ILC. And even if we are talking about the 7 centimeter, it may be the whole extent of the tumor, but the volume of the tumor is different because ILC tends to go as a diffuse, like file-like pattern. So when you take the whole volume of the tumor, it might not be like a whole 7 centimeter mass. That might not be the volume with the ILC. The risk of recurrence is always higher when it actually spreads to the lymph nodes, which we actually, like Dr. Dutta said, we always surprised when we see a lot of sentinel lymph nodes getting positive, when we don't see that even in the MRIs when we go to the surgery. So again, if the patient wants neoadjuvant chemotherapy mainly for margin clearance, or if there is a pectoralis muscle involvement, if I want to get downsize the tumor, or if I want to limit the axillary lymph node dissection, after discussion with the surgeon, I will consider neoadjuvant chemotherapy. If not, I send the patient to surgery and then will look at the final pathology and decide my treatment accordingly.
So I agree with what you said. And in the 90s, when our group was helping develop dose-dense anthracycline and taxane-based chemo, we saw case after case after case of no response to what we thought was the best chemo ever made, right? Dose-dense ACT. And so we've known for a long time that just these tumors don't respond. They're largely luminal A, not exclusively, but largely. But does a test like Oncotype help you identify the small subset that may benefit from chemotherapy?
Are we talking about neoadjuvant or adjuvant chemo?
Either.
Okay. In the neoadjuvant setting, I don't usually go for Oncotype, or some patients comes to me with the mammogram, which is done at the outside center. Sometimes very rarely, some of this lobular cancers may come with a higher Ki-67, very, very rare. In those cases, I consider chemotherapy, but I don't usually rely on any of this mammoprint or the Oncotype scoring in the neoadjuvant setting. In the adjuvant setting also, we have actually a debate about this, the Oncotype or any of these genomic assays, because it's not heavily reliable in lobular. I actually do several projects. I even have just presented at a topic at ASCO on this, presented a poster in ASCO on the same topic, utilization of Oncotype DX in lobular breast cancer, because there is a clinical and genomic discordance in ILC. We see a lot of patients with T3, even with like N1 tumors, T3 N1 tumors, but we may be surprised to see a low Oncotype score in that patients. You may be expecting a higher one, but because of the clinical and the genomic risk discordance, you can see that these patients who has higher clinical risk, but they come up with like a low Oncotype scoring. So if a patient is coming with if the patients, the assay is actually telling us that they have a higher mamma print, or if they have a higher Oncotype scoring, we definitely give them, recommend chemotherapy for that patients. At least we discuss that with the patient, especially if their clinical risk is high. But in ILC, in the adjuvant setting, I mainly go by the clinical risk rather than the genomic risk scoring because of the discordance. Because sometimes
that's a great approach. So Neil, Kevin Kalinsky is my co-chair for the Miami Breast Conference.
Right.
And so what do your med-oncs do in this setting? Are they relying on genomic assays, clinical scores like Aria said? What do you see them doing?
Similar to what Aria said, I think usually we see these cases come to tumor board, they're node positive. We ask the medical oncologist, do we think that we could get a response? And yeah, similar, it's not very optimistic that conventional chemotherapy gets the same response with ILC.
We, as a country, have been behind the curve on neoadjuvant endocrine ablative therapy. The Italians, the French, the British, the Scottish, for years have really jumped into endocrine ablative therapy for these tumors that are addicted to estrogen. We're getting there. We're beginning to do more neoadjuvant, endocrine therapy, particularly in postmenopausal patients. In premenopausal patients, what worries me about the patients I see who have a large lobular cancer, either in the neoadjuvant or the adjuvant setting, where chemotherapy is used to the exclusion of endocrine ablative therapy. So in a postmenopausal patient, you're delaying the therapy that's likely to help them the most by 3 or 4 or 5 months. And that's not great in my opinion. The OFSET trial, which we're part of, will tell us how much of benefit are we getting from chemo blocking estrogen versus the direct cytotoxic effects of the chemotherapy. And the lobular subset of patients, I think, are going to be really important. Arya, you agree?
Yeah, I agree with that, especially in the premenopausal patients, because like we said, most of the lobular is like highly hormone positive. So even if you're giving them the chemotherapy, even if patients with high risk, especially in the premenopausal setting, like we mentioned, that could be just the ovarian suppression effect that happens from the chemotherapy rather than the cytotoxic effect. So that's why when we get the results of the offset, especially in the lobular subtype and also in the premenopausal lobular patients, we will get some, hopefully we'll get some answers from offset, whether it's like the cytotoxic effect versus the ovarian suppression effect from the chemo.
So I'd like to hear from any of you on the call about the nurses, the oncology nurses' role in information dissemination, talking to patients. Can someone sort of talk, or maybe several of you, about this from the nurse's role?
Sure, I can take that on. And Dr. Borgen, I just wanted to add something about the subset of lobular patients. There was a couple of studies presented at Miami Breast last year where they did not present a subset of lobular patients. And I asked the presenter, the PI, the co-PI, and it was interesting. A lot of times, the one I'm thinking about was one of the GLP-1 studies, and they were like, "Oh, that's a good idea. We should include lobular." So I still think we have a disconnect. Maybe Dr. Roy sees that also, a disconnect of making sure the different biology of lobular is studied and reported on when they actually do studies. So it brings me back to where are we with oncology nurses? There is an education problem that people have not been educated to lobular breast cancer. And like I said, 10 years ago when I was diagnosed, no one said from any group that, oh, you have lobular, that's really different. We need to approach it differently. Now I'm getting that and I'm hearing that more, but I think oncology nurses need a lot more education about lobular because they are just saying, oh, it's breast cancer, it's breast cancer. They understand ER/PR, HER2, triple negative, but I don't think they understand the biology behind lobular, why it's treated differently. And I think the Lobular Breast Cancer Alliance, I'm actually part of their education committee, and we're going after breast nurse navigators to educate. We're trying to get into those groups and have education with them to say, hey, this is different. When you see one of these patients in the clinic, get them the right information, talk to them that it's different, that maybe in the survivorship clinic, a mammogram is not going to be the answer. And maybe they're going to have to get an MRI, and it might be an insurance issue that they're going to have to deal with, but it's important that they get that MRI versus the mammogram. So I think we have a long way to go to educate nurses, the advanced practice nurses, and the nurse navigators about lobular. Certainly has improved over the last 10 years.
You know, I'll just say that I agree. It's really improved in the last 10 years. The problem is also is you get these patients who are diagnosed in rural areas who don't have access to these large cancer centers, and their lack of information is even compounded. So I don't even remember. I'm from Los Angeles area. I don't even remember a nurse navigator ever saying anything to me. Not even like, oh, you have breast cancer. I was kind of put out in the wilds. Now, maybe that was because it was 16 years ago. So I think that one of the Lobular Breast Cancer Alliances, one of their main goals is to continue that education. And I know that we have the deal with AONN, and we're looking at how do we get that information into the first responders, so to speak, those nurse navigators, those oncology nurses, and that will be really important.
And many of the lobular patients are not getting chemotherapy, so they're not going into an infusion center where intense education takes place. They may have a whole session on the education and the side effects. So many of us are on CDK4/6 inhibitors and anti-estrogens and other oral meds. So we may not even have time with an oncology nurse educator. And I know it may be intimidating some of my colleagues to talk to me and try to educate me, but it actually has been a deficit in the fact that I'm getting just oral agents and I don't get to see an infusion nurse.
To follow up on Patricia's point with the study reporting, in preparation of this, I was looking it up, and there's a nice manuscript in Nature just a few years ago looking at ILC reporting in randomized trials. And I think it was less than 20% report the ILC rate. And then also made a point that many patients with ILC aren't eligible for some of the metastatic trials because, for example, if their bone lesions aren't lytic, there's not a easy or, a RANO criteria way to measure their response. And so a lot of them are being excluded from trials as well. And is that your?
Actually, Sunil, what you said is exactly correct because in metastatic ILC, most of the time the metastatic pattern is also different. We know that it's mainly like sometimes patients will have peritoneal disease. You cannot measure that. Sometimes patients are like GI. I have so many patients with ILC, predominantly like gastric involvement and also with like colon involvement, and I cannot get them to any trials because like they don't even have bone spots, bone lesions. It's all like GI predominant disease, and they're not measurable, so they don't have like any measurable places. They usually present with like ascites multiple times or like some small PET scan, something is lighting up in the PET scan. So all those patients are actually, we are not able to get them to clinical trials in which they have like more options for like more medicines. Now with the clinical trials, now we are actually in some of these clinical trials, especially in like TAILORx, Responder, we are actually going back, and they're actually going back to see which are the patients which have like ILC versus IDC. And even when I try to look into some alliance, some of our previous alliance trial, like all these trials, they didn't report like ILC versus IDC. So it's just that we don't know the efficacy of like several of these medicines that we are using right now, specifically in ILC.
So I want to touch on two things that you guys are sort of talking about. One is conventional PET scanning has a relatively high chance of missing minimal disease. And so we've pivoted to FES PET, which is specific. Are you guys doing that at Ohio State and at Emory also?
Mhm. At OSU, yes, I actually get FES PET scan. I mean, mainly for identification of metastatic disease in lobular patients, and of course to find if I'm not very sure from where to biopsy is also, I consider FES PET scan mainly. But in most of my ILC patients, I do FES PET scan for identification of metastatic disease. But FES PET scan, the utility is actually, or its efficacy is less in the liver and the GI tract because of the background
Right.
activity. So because of that, when I do the FES PET scan, I always just get a CT of abdomen also, just the abdomen part, just to make sure that I'm not missing that in the liver.
Right.
So,
So
but
are you
we do.
doing FES PET at Emory?
It's a case by case basis, to if we're
Yeah.
looking at additional axillary extent beyond the
Yeah.
dissection, very much case by case. And I will say that and sometimes we do see nodes outside the surgical field, and that is helpful to kind of shape our radiation fields and boost doses for.
Right. So I'm going to come back around to the challenges of MRD analyses with invasive lobular cancers, which do not shed DNA at the same rate as triple negative, HER2 positive. And so that's also going to be another challenge is figuring out the MRD space. You're going to need a really sensitive assay. Aria, let's just touch very briefly on some of the emerging data, for example, the Summit trial that showed lobular cancer patients with HER2 mutations, not amplification, responded to the triplet of neratinib, fulvestrant, and trastuzumab. Do you want to is that one of the future directions for invasive lobular disease?
I would say yes, if the patient actually has the ERBB2, the HER2 mutation, because the most common NGS features or the most common mutations that you see in the lobular breast cancer is mainly, as we know, it's CDH1 mutation, because that's associated with lobular. And at least 50% of the lobular patients also have PIK3CA mutations as well, and that they have either a PIK3CA mutation most of the time, and they may also have an AKT mutation. And some of these patients may also have a HER2 mutation, not amplification, just a mutation. And in metastatic settings, some of these patients may also have an ESR1 mutation also in ILC. So the HER2, I have seen in my practice mainly most of the time when we usually treat these patients with the endocrine treatments in the first line setting, and then sometimes the the ERBB2 mutation can actually happen after that also. So we usually go for the hormone targeting agents or the endocrine treatments in the first line setting for the ILC. But if they're actually having developing an ERBB2 mutation, we can definitely consider some of this HER2 targeting treatments also there. For example, as we know, the TDXT is also like a we can use it for like pan tumor. It's a tumor agnostic anyway. It's approved with the this approval is mainly for tumor agnostic indication. So we can use TDXT also for patients with ERBB2 mutation. And I am considering that for patients, I have like very few patients with the HER2 mutations in which I'm actually trying maybe like one patient in which I have utilized TDXT in later lines. Not upfront, because upfront still the CDK4/6 inhibitors and this endocrine treatments work. But when they are endocrine resistant and if they're developing the ERBB2 mutation, we can definitely consider these medicines.
Sunil, if someone has a relatively small early stage invasive lobular cancer, and maybe based on the age of the patient, they qualify for the choosing wisely approach of omitting a sentinel node, are you still comfortable considering partial breast radiation in patients where we don't have a sentinel node? This is one of our big debates in New York right now.
Kind of think of this as like the stacking de-escalation approaches. And just given that ILC recurrences can be late and they're also underrepresented on the radiation trials, I try to avoid stacking the de-escalation. So for example, if a patient omits sentinel node, even if they're 50 years or older, omits sentinel node based on the sound and SEMA or choosing wisely, that's probably not a patient who has ILC that I would recommend partial breast for. And you can kind of extend that to the lymph node management as well. So if they are a patient that might meet Z11 criteria with 1 to 2 sentinel nodes involved and would be a candidate for whole breast alone, we might consider treating the regional nodes for them. So typically for ILC, while they don't get more dose, their fields typically are broader.
One of the big problems in the community, and we're blessed, and I'm sure you are too at Emory, and I'm sure you are at OSU, is that you really have subspecialized breast pathology. Most places don't. And a lymphocyte in a lymph node is almost indistinguishable from an invasive lobular cell. And so retrospective review from a number of studies across the country where nodes were signed out as negative on IHC looking for epithelial cells that don't belong in lymph nodes, we find that these were incorrectly classified as node negative. And I think that's a real challenge outside of incredible academic centers like yours. That's a real challenge, actually. And we're lucky that with sentinel node, IHC remains a part of the routine evaluation of the node. And so that helps a lot, actually, because that IHC is really looking for those epithelial cells. So going back to Patty and the nurses, what are the most important lessons to patients in terms of you have a new diagnosis? Do you get a second opinion? Do you avoid these sites? Do you avoid your neighbor's advice? What do you recommend to patients?
Well, I always tell them to avoid their neighbor's advice. That's always a disaster. I think a second opinion, which I stayed in the same academic medical center for my second and third opinion. And again, it was 10 years ago. Lobular was not as talked about as it is now. Fortunately, it has come to the forefront. But I think going to a lobular center is something that I should have done before I ended up in the survivorship clinic. It was an insurance issue. My insurance changed. I was able to go to UCSD, even though it's not technically a lobular center, there's a lobular person there. And I think that's really important because it is a very different cancer that needs very different care. And even the PET scan, the estrogen PET scan, I had it done at a non-lobular. And when I got there, the tech said, "Oh, you're getting the special estrogen one. We don't have that radioactive isotope. We're going to have to reschedule you." And anyone that's been a patient and you're got yourself all worked up to have a PET scan to find out if you have metastatic disease, and now you're being told, "Sorry, we have to schedule you 3 weeks from now because we forgot to order the right radioactive isotope." So I think educating oncology nurses, educating the patients to be proactive. I did not, try to get an MRI earlier on, which I probably should have done. So the nurses need to be the patient's advocate. They need to educate for them, send them to the resources, NCCN guidelines, Lobular Breast Cancer Alliance. I think that's really important.
One of the things that we did early on in the LBCA is we connected with ABCD, which is an organization after breast cancer diagnosis, and Share Cancer New York. And they provide one-on-one mentoring to newly diagnosed patients. So like I'm a mentor for both of them. We reached out to the lobular community and said, get trained. So if somebody calls, it's all remote, so you can be in Podunk, West Virginia, and you can get this one-on-one training. They'll match you up with somebody who has a similar diagnosis. And we don't give them advice, but we tell them our journey and we help them develop a list of questions or things that they should be thinking about or that they can do. And because we've been there, I think we give them this modicum of hope that their neighbor doesn't have because they haven't been there. And it is so rewarding to be a mentor for these newly diagnosed patients. And so it's our way of educating them. We're always sending them to the sites that do have evidence-backed information, scientifically sound, recommend the brochures that they can download to bring in with them. And I just think it's a really great resource and probably underused.
Clearly, this story keeps getting more exciting. Aria, going back to you, in these invasive lobular cancers where we see or suspect damaged recombinant, are you going to use PARP inhibitors? We've seen some trial data suggesting that these things mimic the lack of homologous recombination that you see in BRCA1 and PALB2. Do you see the possibility of PARP inhibitors in the future?
In the future, because we don't have a strong data to suggest that all ILC metastatic patients needs needs PARP inhibitors. But if they have a homologous recombinant deficiency, or if they have any of this the germline BRCA mutation or like even somatic BRCA mutations, we know that for somatic BRCA mutations also PARP inhibitors can work from the TBCRC data. So in those patients, yes, we can consider PARP inhibitors. We can definitely use PARP inhibitors for those patients for ILC, but at this time we don't have like that much data to suggest that we can use PARP inhibitors for all ILC patients.
Such an intriguing idea. And of course, there are BRCA tumors that fix their homologous recombination and don't respond to PARP inhibitors. And so it really is about the homologous recombination, not anything else. I suspect that we're getting close to the clock, so I want to give everybody a chance to kind of give us your final thought. Maybe start with Sunil. Final thoughts from your perspective on invasive lobular carcinoma.
The staging is crucial, and to help the radiation oncologist make sure that they get the right radiation plan for them. And just to go back, I think we have some great options now for radiation, convenient, but I would argue that for ILC, given the pattern of spread and the recurrence pattern being late, just be cautious with the trials up to 5 years, and to also consider that with your field design.
Yeah, in almost every trial of luminal A cancers, there were more recurrences in the second 5 years than in the first 5 years. That's just a reality of luminal A breast cancer, and certainly lobular fits in. So Arya, final thoughts about invasive lobular carcinoma?
Sure. So we know that ILCs actually can be sometimes very difficult to find from mammograms. So if you're, even if for patients, I would say that even if your mammogram is coming back as like some cloudy appearance, or even if it's not showing as a mass, always talk to your oncologist or your provider who ordered the mammogram to see if there is a need for an MRI in your case. And also in metastatic ILC patients, also with the, as the metastatic pattern is different from the invasive ductal cancer with like more GI predominant disease or more peritoneal involvement, it's always good to consider newer imaging technologies like FES PET scan, where you will be able to find like more metastatic sites.
Great. Lori?
Yes, we need more ILC specific clinical trials. And in those clinical trials that are just for hormone receptive positive breast cancer, we need histological outcomes reported. The good news is there is such an advancement in the research community. We just have there was just announced an American consortium called LARC, the Lobular American Research Consortium. We have ELBCC, which is the European Lobular Breast Cancer Consortium. We now have kind of a sister advocate organization in Europe of lobular patients. So we're spreading the word. So that's the good news. Now we just need to get some more funding.
Great. Very well said. Patty?
I would say mammography is not always the answer. I think many of us have been lulled into believing that, hey, I had my mammogram done this year, everything is fine. There's still things that you have to do to make sure that your breasts are healthy. Nurses need to be educated. And I made a decision, if people didn't say the word lobular when I was in an appointment, probably wasn't a good fit for me. We should be saying, you have lobular, it's different. And nursing education still needs to grow and develop in that area. And then that lobular can recur 10 years later. It comes to sites that are not the usual sites that we think about with breast cancer. Some are, some aren't. So patients need to be educated to that. And I think we've done a better job with that also.
So many things for the patient's perspective. We didn't mention CDK4/6 inhibitors, but clearly the studies suggest that they're just as important with lobular as with ductal disease. There's a lot of interesting contrast-enhanced mammography, and a number of academic centers are showing real promise with that. But if your center or your hospital or your city doesn't have contrast-enhanced mammography, and you've got a lobular cancer, and your doctor advises against an MRI, it would be time to get a second opinion, because I can tell you, as a surgeon with 30 years of experience, we will fail in the OR if we rely on, even tomosynthesis mammography. We will fail. We cannot plan our surgery. It is not fair to patients to simply wait to see what their margins show. So MRI is central. FES PET is valuable. The disease is fascinating. There are so many things we're learning about invasive lobular carcinoma that, frankly, we didn't know before. I would not underestimate the power of neoadjuvant endocrine ablative therapy with these tumors. I think it's more powerful than we thought 10 years ago or 15 years ago. So your doctor should be well-versed in a lot of the things we're talking about today. These are foundational. There's a lot of more sophisticated stuff that Sunil and Arya could go into. But these foundational level things, your doctor should know. And you have a right to ask those questions and get those answers. So I think with that, I'm going to thank my panel for a very provocative, interesting discussion about an incredibly important disease.